Welcome to the EMT Pro podcast, where we deliver relevant EMS content from the field and the classroom each week. Episodes of this podcast can get you 1 full hour of CE through our partner emt-ce.com, so head over there for more information. I'm your host, Steve Williams, and with me today is Dan and Holly. Guys, say hi.
Steve,
good morning.
Good morning. I'm good. I'm doing really good, actually.
I'm doing great after this coffee you bought me.
Oh, I'm happy to hear that. We've got a awesome episode planned. It's actually going to be a 2-part series, we've decided, on basically everything ketamine related.
Yes,
We've got
excited.
An awesome guest today. He's actually a former intern of mine that I had when he was in paramedic school. His name's Isaiah Burkhart, and we'll get him on here in just a second. And then our next episode will be with our staff physician, Dr. Selbach, and he's going to give us the ER physician side of ketamine and to talk to us about everything that he sees with it, good, bad, ugly, everything. So I think it's going to be really fun.
Yeah, it's going to be
This is one of those drugs, as you guys know, is a little controversial, a little bit, some docs love it. Some docs, really freak out when they find out their patient's coming in with it administered. And there's a lot that's just kind of unknown about it. So,
well, they need to do the research because it's a great drug.
It is a great drug.
It is, and even a couple years ago in EMS, it was so controversial with the TBI and this and, all the misinformation.
It still is.
It still is.
Yeah.
I love it because it keeps us safe. I've had numerous calls over the last 15 years where we didn't have ketamine on board and we tried Versed first. And when you have certain overdoses that people are completely tripping out on, they metabolize that Versed so fast it doesn't do anything, but maybe slow them down 10%.
Yeah.
Yeah, and it also hits a different receptor
totally different
mechanism in the brain than the ketamine does.
Well, hey, let's get Isaiah on, and we'll kind of get this episode rolling. Sound good?
Sounds good.
Sounds great.
Okay, hey, Isaiah, are you there?
Yeah, I'm here. I'm here, Steve.
Awesome. Cool, man. Really excited to have you on the show today. As you know, we're talking about ketamine, and I'm really interested to get your background on it because, and I'll let you kind of explain all of that, but Special Forces guy, and then currently working in fire and EMS, so really interested to get your take on things. And then the other thing is we're going to have this 2-part series where we kind of do some case studies now, and then we bring our friend Dr. Selbach on to kind of do more of the background on it, the actual information on the drug itself, pharmacodynamics, kinetics, and everything else. So this should be fun. You give me the spiel, because I know it was Special Forces, but I'm going to get all the other information wrong. So.
So I was in 3rd Ranger Battalion, 75th Ranger Regiment for 6 years, from 2000. I went in the service in 2002, and then with all the training and stuff, by the time I got in there, it was 2003. Got out in 2008, and then I did another 5 years in the National Guard, just in Oregon, kind of double dipping my GI / the National Guard paying for some stuff, and went and got a biology degree at OSU and stuff, and thought I wanted to go to vet school, and then changed my mind on that and went to paramedic school. And then, that was actually kind of the time right around then when I met Steve, and he actually ended up being my preceptor with too much chagrin initially, I think, being like, really? You guys gave me another person?
How was he as a preceptor? Because he really toots his own horn being a 5-star medic. I'm just curious on how he is.
He got me ready. I can say that for sure. Because I feel like and I think this is true for me still, and I think it's an issue with a lot of people, is just I was really good under high stress situations because that was how I was trained to. I mean, we used to do these just in training, these gnarly stress shoots where they would get you completely exhausted and not able to think straight on your feet kind of thing. And then you have to perform these tasks and, at a really super high level. And so we used to do that all the time. So I was really good. And I mean, there's many times where I'm in situations where I was like, I would literally rather be in a firefight right now with rounds skipping off the ground around me than where I'm at right now. Uncomfortable social situations, where I'm like, dude, put me in a firefight right now. And I'm way more in my element because I know what my duties are and I know what I'd be doing and I know the outcome. Whereas these like, it's like going on a really like those calls that are like, it's maybe a psych call or something. And you're like trying to figure out what the heck can I do here? This is like a really uncomfortable, maybe it's a family problem thing. Yeah. It's like, so Steve got me ready for like, I think on that side of things, like prepared more in the sense of like, obviously medical side of stuff, really prepared. There's still things that I remember he told me that I'm like, yeah, I still don't have that down all the way yet. Because the scope of some of the things, people are like, yeah, dude, that's like beyond paramedic stuff. And I'm like, well, you know, maybe we should start doing that.
Yeah. So. I remember going to town on just random classes with you and just, yeah, way over prepared you, but it was a good thing.
I'm thinking back when I was a preceptor, we did Mad Libs and played Frisbee.
Crossword puzzles.
No, exactly.
That's rad. I remember my first day with Isaiah as an intern. He would show up and we'd go on these calls, and I'm kind of standing back, right? Because that's kind of your job, is to let them kind of run things until they get into a pickle and then come in and see what you can do to fix it. And he had this in my lieutenant at the time was the one who noticed it. He's like, watch this guy. And I go, yeah, I know. He's kind of like looking people up and down and like assessing the scene. And he had this like complete awareness of his surroundings because he was sizing people up. Like, is this a threat?
Right.
Mm-hmm.
And it was a weird, not weird, but it was a challenge to take someone who has that high of a, situational awareness and kind of take it down a notch to, hey man, we're here to, this is our person. Like,
that's
awesome
the opposite of what you're normally teaching.
Yeah, but scene safety is something we briefly ensure that we have, and then we're on to 100% patient contact. And he was like, scene safety, scene safety, scene safety, scene safety.
Right.
And so,
but you know what? On a side note,
it was good.
On a side note, that would be a great topic for
it really would.
podcast.
Yeah, Isaiah, you said that you had a couple things that you wanted to bring up, right?
Well, yeah. I mean, my initial experience with ketamine was when I was a teenager, and one of my buddies was like, hey, I got this stuff, took ketamine. We're like sitting on his couch in his living room, like tries to stand up, takes one step, like takes a header right into the coffee table and knocks himself out. And I'm like, what is this stuff? And I'm like a teenager. I maybe smoked pot a couple times and stuff like that growing up. And I'm like, oh my God, this is scary. Like, it's terrifying. And then like it fast forward like years later, and I'm like, oh yeah, there's that drug, like veterinarians use it. I remember like one of my buddies trying to use it with like not a very good outcome. And then, fast forward into getting into becoming a paramedic, and I'm like, oh, this is a really useful drug. And then more recently, it like one of my first calls when I was up in fire was a guy that basically went into what we would call an excited delirium, right? And I'm like pretty new, and we end up like dosing this guy with a really high dose. I think we did probably somewhere around 400 milligrams of ketamine on this guy, like in 2 separate doses. And I remember like the sheriffs. This was like out in the county, outside of town, and the sheriffs are like, there's like 5 guys on top of this guy, just trying to hold him down because he's like freaking out, like he's pulling his own hair out, like scratching at himself. I mean, it's just like totally that typical, like, well, I guess there is no really typical excited delirium, but I know you guys have all seen some sort of semblance of that, where it's like, wow, this person's like running naked down the middle of the highway kind of thing, and they're going to get themselves or somebody else injured, right? And so we're trying to do something to just like stop the process. And watching this happen, and then being like, giving like 400 milligrams of ketamine and like sitting there and being like, wow, this is like taking a while. And I remember even one of the sheriffs like looking up over at me, and he's like, drenched in sweat, like just trying to hold this guy down. And, and it's like a totally appropriate situation. It was just like, I think it's nerve wracking for everybody. And they're like looking at me going, how long is this supposed to take, dude? Like, are we, like, is this going to kick in? And I remember we ended up actually giving the guy, I think, like another 2.5 of Versed. And then finally, after a couple minutes, like he just sedated, we get him on the gurney and get him to the hospital. Everything is fine from there. So that was like one of my first. And
I'm assuming that was IM based on his excited delirium.
Yes.
Hold still while we start an IV.
All of that. Yeah. So all of that was all IM.
Mm-hmm.
Yeah.
Yeah.
So, we've added then, quite a process with ketamine where we've kind of changed protocols many times. And even recently we've like added some things and taken certain things away. Like, yeah, you can do this or you can't do that.
We should say, what was your first experience giving ketamine? Do you remember your very first call ever?
Yeah, no, that excited delirium call where like the sheriffs were trying to hold the kid down and stuff. That was
your very first experience.
Yeah, I was like 2 weeks on probation kind of thing. And I'm like, what is this?
You know what's weird, Isaiah, is I used to work in the city next to you on the helicopter, and the only 2 times I've given IM ketamine was over there on car wrecks, and it worked amazing. And we didn't have to RSIM.
Yeah,
it was that good.
What was the first time you ever gave it? Do you remember?
I think it was just RSI.
Yeah, RSI.
Yeah, RSI. Yeah.
So my first is a pretty epic story. The quick synopsis is we hear an ambulance get tapped out for a police issue. Again, these police issues become ketamine calls, I swear.
I know.
Oh, no, that's 100%. Yeah.
Yeah. And so we're hearing this, and it's at a bank about just a few blocks from our station. And I'm like, this kind of sounds a little squirrely. Maybe we should, assign ourselves to this call and go give them some help, because we only have 2-person medics. And so they're rolling around, and we want to make sure they have enough hands on scene if they need to. So we self-dispatch, which we have an okay to do for calls in our district. And we head there, and we're the first ones on scene because it's literally, 3-4 blocks from our station. And the cop meets me outside, and he goes, "Hey, here's what we got. This guy walked into the bank, took off his clothes, and basically told the entire group in there that was in the bank that he's going to kill them all, and God had sent him here to do this." Like, oh, okay. Well, this is interesting. So this guy is currently has 1 foot inside the cop car, and there's only 2 cops. He's handcuffed, but he's only got 1 foot in, and they
is he still naked?
Yeah. And they can't get him into the
They're slippery when they're naked.
Oh, yeah.
They're very slippery. And not to mention, this is broad daylight. So there's 50 people with their phones out filming everything, right? So walk up, and I introduce myself because I'm like, I'll just kill him with kindness, right? This will be no big deal. And this guy's, butt naked looking at me, and he goes, I told him, "Hi, my name's Steve, I'm a paramedic. What's going on? You doing okay?" And he said, "Oh, Steve, yeah, I knew that was your name." He goes, "I created you after all." And I go, oh, that's interesting. I've never had anyone tell me they created me. And he goes, "Yeah, God sent me here to do this or that or whatever." And he's like looking through me. Like I'm not even in his presence, right? I'm not even on his radar. And so right around this time, I decide, well, we're not going to do this kill him with kindness route anymore. We're going to have to sedate this guy because he's actively fighting getting in this police car. More cops show up. Our ambulance crew shows up, and we come up with this plan of, hey, we're going to, we always, when we make these plans, it's always, okay, right arm, left leg, right leg, and whoever's there to help, hold the rest, let's, make sure we get them, good and secured down.
Especially when they're naked. So get this guy, put him on the cot, and then we just, did IM at that point too. And he was in mid-sentence, just telling these cops everything he thought about them, and he was just done.
And it was, mouth is still open, like, cover him up, take him up to the hospital and everything. But he was on bath salts. That's what we found out.
And that was in your protocol at the time?
Mm-hmm. This was within the first 3 months of having it in our protocols. This call came in, and awesome drug though. But my learning points for it are, and they're actually in our protocols now. We've updated it a few times as we've gotten more calls giving it. We have to give 1 to 2.5 milligrams of Versed to help with that emergent reaction, and then we also have to give Zofran just for potential puking and having a compromised airway. But that's
really the only kind of two things that I know that we do that may be a little bit different from folks, but.
Yeah, when we first put ketamine in our protocols, we had to give it with fentanyl. It wasn't just a sole pain management tool. It was along with a narcotic.
Yeah, we had to give 200 before we gave the ketamine.
Yeah, and we had a similar, I believe initially when they added it into the pain management, it's different now. I'm trying to remember what the protocol was, but I believe it was initially like, if you've given, fentanyl with no relief, basically you can go to this low dose of ketamine to see if it'll help. So that was like kind of like we're just going to, fortunately, like one of our medical directors is a retired naval flight surgeon. So he used it a ton and he's a big fan of it. So like, I think a lot of it is like, I don't know where it came from or what, but it seems like in certain parts of the medical community, there's like this stigma with ketamine.
Well, there was the whole
maybe because
thing
it's
if you can't give it in
unknown.
TBI, and that was the misinformation for so long that people believed it wholeheartedly. And thankfully,
there was like a 3-person study.
It was done in
neonatal from like 10 years ago. Yeah,
with hydrocephalus.
Right.
That was the study.
Yeah.
So when you were in the military, how frequently was it used back in the early 2000s?
As far as I remember it, regular. I mean, that was kind of the drug that our medics used. And I mean, our medics, like in Ranger Battalion, are fantastic. They're basically, they go to the same course that like all the, special forces, medics go, and any of the, the guys from Delta or anything like that, all their medics. So it's like, it's the high level, like SOMC or SOCM, people call it, at Fort Bragg. And it's like, this super expensive course, and these guys, and they're, doing goat labs and using ketamine and all this stuff. And yeah, I mean, fortunately I did 6 deployments overseas, and, I was fortunate enough to not be around a lot of our guys getting injured that frequently, or, any sort of like massive catastrophic injuries, really, really close calls. There were definitely platoons in my battalion that had that, but I just always ended up being with groups, it seemed like, where we didn't have that much of it. But the times they were used, ketamine was the drug of choice. And from, our medics were huge fans of it. And that was like really when I first was kind of changed my mind on it, from the couch experience with my buddy in high school to like our medics being like, oh, this is like a really, really good drug, I'm like, okay, if you say so.
Yeah. Oh, man. That's awesome.
Yeah. And then on that side of it with ketamine, my daughter last year, she breaks her arm in the classroom. She's in my daughter's class. As a first grader. So it's like, had this whole set. Okay, you want to have your daughter in the class. Okay.
She's in your wife's class, right?
In my wife's class. So my daughter's in my wife's class, and she breaks her arm in the classroom. Full on radius ulna, like looked like a teepee kind of thing. And I'm on, of course, it happens while I'm on duty, and I happen to be like, we have a situation, like a BLS program, and I was working on our SUV, where I'm like the paramedic that goes with the EMTs on the medic. So I'm like, I get called, and I'm like, oh, I got to go to the ER. My daughter's at the ER. So I show up, I'm like, oh, and she's sitting there, sobbing. They've got a towel hanging over it. And I'm like, all right, lift it up. Let me see that thing. It's probably not that bad. She lifts her arm up, and I'm like, oh, okay. Yeah. Hey, when can we get her in? Like, when can we not be in the waiting room any longer?
Yeah, no kidding.
And, and so they ended up giving her, ketamine they had to reduce it. And, they gave her ketamine, like in one of the trauma rooms in the ER, and put her under, reduced it. And, I ended up taking off the rest of the day. He got me a release for the rest of the day, just so I could be in the ER with my daughter. And just the experience, I've been on many calls where we give the ketamine, but I never get to see what the reaction is of the people when they're coming off of it.
Mm-hmm.
So that's like one thing that I don't have that experience. like, Holly, you probably have that experience because you're a nurse, you work in a hospital, you see people who like, okay, they're coming back off of it. Whereas like, I'd never experienced that before. And all of a sudden I'm like, whoa, my daughter's like what we would call tripping out, right? Like,
they're like little drunk people in the ER.
So what was
exactly? And
what was that like?
She was telling me, it was a little nerve wracking, but also like once I realized that it was actually fairly positive things that she was like, you know, she was having a little delusions, some hallucinations. Like she told me that there were hamburgers all over the ceiling and then she was going to eat the ceiling.
Oh my
and I'm
God.
like, okay. I was like, okay. And I just kind of rolled with it. I was like, oh, there's hamburgers on the ceiling. Awesome. Like, how many are you going to eat? You know? And she's like telling me all this. And, you know, the doctor who just did the reduction comes in the room and she's like, why do you have two heads? Is what she asked him.
Did she have nystagmus?
Like,
did you notice?
Yes, she did. Yeah, she had nystagmus.
Big time.
For sure. Yeah. And that was why I was like, oh, that's why she's like seeing double, I'm assuming. And, but yeah, it was one of those experiences where I was like, okay, but then when we were all done with it and having conversations with her, I mean, she's about to turn 8 now. This was just before, so she was 6 when this happened, and it was just before her 7th birthday. And, you know, for a little girl, I mean, it's my daughter, so it's like, I'd, you know, burn down the world to save her probably. And, I'm like, you know, it's really nerve wracking. And I'm like, well, I have to understand, like, I'm giving this to patients. Like, why am I so scared that they gave this to my daughter? And then seeing the reaction afterwards, yeah, there were some interesting conversations with her. But now when I ask her about the experience, she doesn't have any of this, like, negative thought of, like, the actual breaking her arm. Like, to her, it wasn't a big deal. And, you know, she does remember some of the stuff in the hospital after, like, coming off those conversations. And she said she remembers, like, the doctor looking like what she said in Alien and stuff like that. But to her, it's not like a negative experience. And so I was like, okay, this definitely is a really, like, to me, it seemed like, okay, this is safe. It almost was like the light bulb went off and I'm like, yeah, this is a really safe drug to use in that sense, because like I also have never seen anybody get like, you know, gnarly respiratory depression, like when we've given too much fentanyl or too much Versed or something like that.
That's interesting you say that, because in the ER, especially for the pediatric population, we would do reductions all the time with ketamine, because the alternative is propofol and fentanyl, and you have to have the airway roll ready, and they have to be, of course we're monitoring them anyways, but you have to be ready to intubate, because they can definitely have decreased respirations or decreased blood pressure, and the whole the preparation and the side effects are so much greater than just giving a little dissociative ketamine to get through the process. And
absolutely. And just like one additional thing that just more recently, while I'm becoming even more, I kind of like really jazzed on ketamine right now, actually. So
you're on ketamine
right now? I'm really jazzed about it. Yeah, so really, really jazzed about it. And one of the big reasons is it's just like seeing the positive psychological effect that it's having in the the veteran community, in a sense, because and then also just people with severe depression and all of the new advances that are coming out with it. I have a really close friend who is using, actually has gone to 3 sessions for ketamine therapy for basically this like what they call like a non-treatable depression, or like very, very high anxiety. He's in a super high stress job with a lot of responsibility, and just nothing's been working. I mean, he's just been kind of pinging for the last, you know, year of his life, and like really stressed out, and just like it's affected a lot of different things in his life. And he's gone 3 times. We've had conversations after each of them, and it's like, you know, he told me the negatives and the positives, but overall, he's like, this is changing my life. Like, my anxiety level is at all-time low. I'm, you know,
wow.
and it's it's really cool to see. And I mean, there's so much of the like physiologically, like is it actually doing in the brain? Like what is it doing? And that like with different receptors and things and creating different neural connections and all that stuff. And it's just a really interesting drug that I think is in the EMS community is almost like in the field is almost underutilized.
Mm-hmm.
Oh, absolutely.
I think for so long we've been like narcs, benzos, and I'm like, wait, we got this really cool thing right here that can do a lot of what those do, but without the long-term side effects or potential, addictive properties that those have.
Right.
Yeah, it is underutilized, and I started doing this a long time ago, but really in the big scheme of things, it was 2002. And we didn't sedate after intubation. We didn't give pain medications for abdominal or back pain. We were just so stingy with any kind of sedation or pain management. So really putting ketamine into our toolbox, that toolbox really doesn't have very many tools in it to begin with.
No.
So I love that we're being able to use ketamine more and more. But you're right. It's completely underutilized. Pain management and sedation is underutilized anyway in EMS. But I hope ketamine will replace some of those other things that we have.
Hey, Isaiah, question for you, buddy. So in your protocols,
yes,
you actually have a protocol for excited delirium?
So it's under our altered mental status protocol. There's like a sub bullet in there for excited delirium. And so we basically run, obviously we're assuming that if the person has excited delirium that we're doing an IM dose. And we do, it's 2 to 4 milligrams per kilogram.
3 to 4, you said?
2 to 4. 2 to 4. Yeah. And that's the thing. So, and then we also we use it so we have it. Yeah, it is a lot. So, and honestly, I've when we were first using it, it was like 2 to 4 and everybody was just like using 4 and it was like a huge dose, right? It seemed like that. I haven't been on one of those actually in quite some time, but there was kind of I think we had either just like, I think it was basically like, people are calling it excited delirium. What I think more attributed to is we got like in town, there was a gnarly batch of meth going around.
Right.
And people were going into like these really crazy, like meth psychosis events where, they're getting really hot. I don't know if they're mixing it with other synthetic street drugs or things like that, like what old school, like bath salt style stuff or what, but, and that's the bad, not I guess say bad part, but the thing that we don't find a lot. I mean, we have our case reviews and stuff like that, but there's a lot of cases where many times we don't find out. We don't get to see the drug screen after the fact and actually see like, oh, what was that guy on, or what's the talk screen say. Whereas like being in the field, so it's like we go on to our next call and we get off shift and then you kind of forget about it. But so we use it for excited delirium, and then we also like and that's really, and when I know you had sent some stuff just to talk about mixing ketamine with benzos, and really the only spot in our protocol where we would do that is basically like a continued sedation for somebody with excited delirium. So it's like we give them the initial dose of ketamine, it's good to go, and then maybe we'll give them like 2.5 IV of Versed for a continued sedation if we we're out far enough where we need that. But being like, in Bend, Oregon, like none of our ASA goes out, 69 miles outside of town, like east. So it goes really far, but at the same time, there's not a high population out there. So we're not really going on these types of calls. It's pretty much in town, and most of our transports are less than 10 minutes on average. So it's like, are we needing the continued sedation? Rarely.
Right.
So it's not something that we do a lot. So I don't have a lot of experience of like seeing any like negative side effects necessarily with mixing benzos with ketamine.
The stuff that I've seen,
we use it for pain. Oh, go ahead.
The stuff that I've seen is more geared towards, you give the benzo for a couple different reasons. One is that continued sedation, but the second is to help with that emergence reaction that comes from people coming out of ketamine.
And generally, it's before, right? You give the benzo before, and then you give the ketamine.
When we can, that's what we do.
Right.
But we've had a few instances where we have to give the ketamine first just due
just
to
to calm them down.
Crazy, stuff going on.
So can I pop in real quick? So it's 2 to 4 milligrams per kilogram, and something I finally learned.
I'm wondering though, real quick on that dose. I'm wondering if the 2 is for IV and the IM is for 4. Is that what you guys do?
No, it's just 2 to 4 IM, and I'm not.
Okay.
I can't. I can't give you a.
Got it.
Yeah, that's all IM. Yeah, that's
all IM.
All IM.
Okay.
Yeah.
Which makes sense because you wouldn't be
You're not
probably wouldn't have an IV in that patient.
Right. And our dose is 2 milligrams IV of ketamine.
Okay.
4 milligrams IM.
So
that makes a lot more
with
sense.
a repeat dose of 0.5 to 1.
That's for excited delirium?
That's for chemical restraint, yeah.
Okay.
For excited.
Yeah.
So we don't have that in Tri-County area.
Yeah.
And that's one of our problems is we have to, like the other day, I had to kind of fidget things around to try to work it as a pain dose, which is way too low. It didn't even touch them. But something, I've overdosed a lot of people on ketamine, and you can't really overdose them. They hit that threshold of dissociation, and it just makes it go longer and longer. It doesn't do anything else.
Yeah.
So it's just, and it scared
absolutely.
me to death. I thought, oh my gosh, I'm going to deliver this guy to the hospital. He's going to die. And it just extends it out longer and longer, which is okay.
Well, and it doesn't.
It's okay for, I think, for what we do. And then I know that we had talked about this before, but Justin Lassick had written a paper about his own experience with ketamine and how actually terrifying it is to have solely ketamine on board because time doesn't mean anything. If there's any aggression toward you, it's life or death. It feels like you're in this because you're in that dissociative state. It's just like a conversation you have right now, hold still.
Right.
That repeats for hours or days, and you're just kind of in this crazy state of panic.
Yeah. And
right. And so we never really I've never considered that until reading that personal experience, that maybe for our patients, throwing that benzo on board, if it's safe, might be a better thing for them. We are really thinking about us and our safety and getting the patient to the hospital. But as we grow with our ketamine experience, hopefully we can take that in consideration too.
Yeah. I think the thing that Justin's paper actually changed my course of action on a call just this last couple of weeks. It was a pretty awesome call, start to finish. So we had responded to a call. There was I don't even remember what they tapped it out as, but it was a code 1 police request for eval or something like that. And so I'm getting in the rig, looking at our computer, going, okay, what are we going on? And I'm reading that the police haven't even gotten on scene yet. They just requested us to the scene after getting the info themselves. So we show up right around the same time. Engine, ambulance, and 3 police officers. And we're met outside by girlfriend and roommate of this college student. And we're talking to them, and they say, you can tell, like, things are messed up, that something's not going right. They're really worried. And they're saying, yeah, he just took these 3 acid pills, don't know anything else about him, but he's completely out of it. We're like, okay. And so we're on this driveway, and it's kind of hard to explain, but they point down to this basement apartment window. And so we can look in the window and see this guy breaking anything that was breakable. Like, he's just going nuts in this apartment. And so I'm thinking about Justin's paper that he wrote, and we'll put that paper in the show notes on our website. And that thought goes through my brain of, okay, we need to do what we have to do, but we have to make sure that once he has ketamine on board, because that was going to be our drug of choice, that we've got to make sure that everybody's talking to him, calmly and gently, and not amping anything up with unneeded, words or aggression or anything like that. So we tell these 3 police officers, hey, this is the plan. This is what we're going to do once you guys essentially go in there and help us restrain him. And they're like, okay, yeah, sounds good. So we are probably 15 feet back, a room away from these 3 police officers that go in. And we told them what we needed them to do, right, by like talking sweet and everything. And this guy, big cop.
Right.
And he's, first in the door, and he's, let's say this guy's name is Josh. Hey, Josh. All right, buddy. Hey, man, so we need you to, kind of calm down. And Josh, is so high out of his mind. He has no idea what's going on, right? He turns and just charges right at the officer, and the cop, I hear him go, oh, bad decision. And then I hear, bam, this guy just gets flattened, right? And so now this cop's on top of this kid, and he's like, hey, Josh, hey, buddy, bad decision, but hey, we're going to be okay. We're going to get you taken care of, And so we go in, give this guy, we gave him 300 total IM. And the thing that I love about ketamine is how quickly it is, how quickly it acts. IM, you see them out within a minute or two. It seems like they really start to slow down, and they're completely out within just a few. But everybody was on board with this, like talking nicely to this kid. And
boy, that doesn't happen.
I love that.
No, it was great.
I love that.
And then the best part was, though, these cops went outside and were giving reports to the roommate and to the girlfriend, and just saying, hey, I know that this looks, kind of crazy to see us dogpile on this kid, but it's really for his safety. We're making sure that he's going to get taken up to the hospital and get taken care of. And it was just overall like a really, really cool thing. And I actually sent their sergeant a note and just said, hey, these guys crushed this call. Like
nice.
It was awesome. It was really happy to work so well with them.
But I think we need more of that too, like that positive reinforcement, especially in our law enforcement community, because we work so closely with these guys. And I know, like, I work with so many guys here and then that are just fantastic humans and individuals that are trying to do a really good thing for their community. And it's been really, obviously our political climate. And
it makes me wonder what else what other kind of trauma we're providing for our patients when we're sedating them and then throwing them in helicopters and, doing all that kind of stuff, because we don't get to interview them afterwards.
Right.
How was your experience?
Yeah.
100%.
And maybe they just didn't have the wherewithal or like the mental fortitude to write this amazing paper like Justin wrote, to try to educate all of us on what it's really like. It's really fascinating.
Totally.
And makes me think of all the times I have done it wrong.
Yeah.
Yeah.
For sure.
It was interesting too. My close friend who's done this ketamine therapy just for the anti-anxiety stuff a few times, and him just bringing up, he doesn't know like the necessary like medical lingo stuff of like, because we added in our protocols. There was a period where I don't know, maybe it was 2 years ago or something, where we literally couldn't get fentanyl. There was like supposedly some national fentanyl shortage or something. And so all we had was morphine for basically a narc for pain management. And, how many people have we gone on that you ask them what they're allergic to, and it's like, your standard penicillin, whatever. And it's always like codeine or morphine. They're like, oh, I'm allergic to it. Well, what happened? So I got really sick. Well, you're probably not actually allergic. You just like, it makes people sick a lot of times. Well, I ended up going on like a hip fracture on a lady. And this was during that period of time. And she was like, she fell on her back, went gardening, fell out. She's obviously got like a pretty severe injury. She's in a lot of pain. And she ends up, I'm just talking to her, okay, this is what I'm going to do. She's like, hey, whatever you tell me, just let me know what you're doing. I'm a retired ICU nurse, and I just want to know what you're giving me and all that stuff. Oh, okay, absolutely. Ask her allergies. She says, well, I am legitimately allergic to morphine. Like, I will break out in hives if I get it. And I'm like, oh, okay, well, we don't want to do that. Well, we had because of this, they're like, we need to have another pain control type thing. So they added ketamine in as a pain management dose. It was like, we're just doing this kind of temporarily to like, I think kind of trial run it in a way. I think the fear of it is people are like, oh, if we give them this dose, they're going to go totally trip out and have this horrible psychological experience and all these things. And, I gave this, this was like my first like experience was just giving it as a pain dose. And at the time, I think our protocol was like 0.3 milligrams per kilogram or something, was it? Now we've adjusted it, and we actually have it in our pain management protocol, and it's a 0.5 milligrams per kilogram. And then we also have the option of doing, and that's like a direct like IV push if you were going to do it. But at the same time, we've also added in it's a 2 milligrams per kilogram. Oh, sorry, I'm thinking about the wrong thing. I'm thinking about post-catastrophic. We've added in a few different other things, but we've got it basically where you can do 0.2 milligrams per kilogram into like 100 bag of normal saline and do this slow IV push for it. And then that got me thinking like, okay, well, what's the difference between pushing this slowly and pushing this quickly? And then talking with and I've read some stuff and some research, basically it's like reinforces the slow IV push. It generally has less long-term effects on it. And Justin even talked about that in that paper that he wrote about having the slow push actually gave a better reaction to it. Basically. And with my friend talking with him, the doctor that's working with him with this ketamine therapy, basically gave him the option. Okay, we're going to try to do we're going to do a faster push for one day, and then we're going to do a slow push. And I want to see which one you actually have a better reaction to, because they're not really sure why it reacts certain ways with some people, like why it's a bad reaction with some and a good reaction with other people. And yeah, it was interesting here talking to him, talking about, she did, a fast push for one of them, and it was way too much. He was saying it was I didn't like it. It didn't have a positive necessarily. It wasn't a negative effect he was talking about, but not nearly a positive. Whereas he's the other session, we had the slow IV push, and it was oh. And I'm wow, it's really cool to talk to somebody who's experienced that and not necessarily a pain management or catastrophic situation or excited delirium or whatever we're giving it for, but just as hey, which made me go, I started doing a little bit more research on ketamine, and I'm oh wow, the FDA approved in 2019 the use of what they're calling R-ketamine. There's an R-ketamine and S-ketamine, which are basically isomers of ketamine that they created that are less I want to just say less lethal, but not that. Right. They're basically less, just a lower dose in a sense. I'm not exactly sure behind the exact mechanism of action for it, but all I know is they're basically developed this nasal spray of S-ketamine, and basically they're saying that this is for antidepressant is just having a massive psychological benefit for people who have a suicidal ideation type. And I was wow, man, this could be a huge game changer in EMS, even where if that was a potential thing that we carried, they're saying so with a normal antidepressant, it takes it can take up to 10 days, 2 weeks before the antidepressants actually start working in your system where you're actually feeling the effect of it. Whereas this, they're saying it can take effect within 10 minutes. So somebody who's potentially wanting to, kill themselves, we give them, hey, we're going to give you this nasal spray, and then potentially within 10 minutes, those suicidal ideations, I'm not going to say they're going to go away, but you've got a dumbing down of it where maybe you're taking some of that depressive factor and removing it, or at least inhibiting it.
Yeah, that's rad.
And so it's just there's just so much cool stuff coming
There's so
out
much
with
to
it that I'm wow, this is so rad. This drug was essentially what? It was taken from, PCP was created back in the 50s, and then this drug came from, our street term of angel dust, which is kind of okay, this is crazy. And they created this thing, from what was PCP and created this drug that now I think has so many more uses, especially in EMS and in the pre-hospital and hospital setting. So anyway, that's part of the reason why I'm so excited about it, because of the advances and just the safety factor in it.
Right.
no respiratory depression, I'm not going to completely, like, there's not the potential I'm going to kill this guy.
I think the only thing I can think of off the top of my head that ketamine can be potentially dangerous for would be induction with sepsis or induction in an event where you have used up all of your catecholamines. In that case, you can get some hypotension and maybe half the dose.
Yeah,
but
half to quarter of a dose.
Yeah, but again, you're not. What's your alternative?
Yeah.
It is a pretty safe.
It is
safe medication.
Well, I feel like we should put this out there. Obviously, follow your local protocols. We're not suggesting you give any dose that you're hearing on our podcast. But Isaiah, in your protocols, what are the reasons that you can give ketamine for?
So we've got we talked about excited delirium and
that's chemical restraint.
Yeah, so chemical restraint and for pain management. The big one that we just added in, and this was a push from kind of most of the guys on the line, but it was specifically from one guy that heads up like our extrication stuff, was we were having a number of pretty extensive, like, I'm working now at a different station with a medic, and I was an ambulance and an engine, so I kind of swap back and forth. Previously, the last couple of years, I was at our truck station. So I was on the truck with all of our, in how we operate, we'll probably get shot down from people with this, but like not every single one of our engines has, home outro tools or whatever tool you guys use, or Hearst tools, on them. So we have a dedicated couple rescues, like a rescue truck and then basically a backup rescue. And those all have tools on them. So I was working at that station, but we kept running into these calls where like, these extrications are pretty complicated. We had a guy on 97 who went the other lane and got basically ran over by a dump truck. Like a legitimately like huge giant dump truck ran over his car. And, so the guy's alive, severe pain. He's got like leg entrapment. And the thought was, hey, can we give just an IM disassociative dose to this guy? Like, while they're in this entrapped, while we're trying to cut them out of this thing, and then, after reading the paper and stuff, I'm like, it seems like we've had positive effect from that. But at the same time, I'm like, man, are we like causing massive psychological trauma at the same time because of like this dude's in the car and we're like cutting the roof off around him, and in Justin's paper, he's talking specifically about like loud noises and all these different things. And I'm like, oh man, maybe this is like causing some harm. But at the same time, we're not seeing like before there's been the real kind of people have held back from, like giving like a fentanyl dose or something like that while they're in this situation, because we really don't know like what the extent of the injuries are. Are we, do we have some sort of lung injury that we don't necessarily know about that we're going to cause more respiratory depression and cause further harm to the patient?
And initial safety is the most important thing too. If they're being combative in there, you have to do something.
So just to get this straight though,
exactly.
You guys have chemical restraint, alternative analgesia, and then do you guys do induction for RSI?
Yes. Yeah, we do. We also have it for induction. And I'd say that's honestly probably I don't want to say the most, because it's not like we're RSIing people left and right. It's funny. We talked about doing this, and then just 3 days ago on day one when I was on shift, we had a vehicle versus pedestrian on the parkway here in town. So highway speed, the speed limit is supposed to be 45 going through town on it, but people drive 65. And a teenage boy crossing the parkway. So there's one of those blinking lights they can hit and be able to cross the highway, which nobody's stoked that they have that there, because it's like, why would you put a crosswalk on essentially what some people would call an interstate? So kid tries to cross. Somebody from out of town doesn't recognize the yellow lights and basically hits this kid at highway speed. He obviously wasn't paying attention to see the traffic was stopping. So, and our station was just around the corner. We get there on scene, and we got this a huge crowd. The traffic's backed up everywhere, and there's one lady holding C-spine for this poor kid, and it's like GCS is like 4, I mean, he's completely responsive. He's got the cerebral posturing going on. Like, he's obviously got a severe head injury. But at the same time, we're like, well, what can we do? So we just load and go. And we were, to toot my own horn, we were pretty stoked. We had like from initiation of call to dropping the patient off in the trauma room at the hospital with 25 minutes.
Nice.
Awesome.
So we're like, we felt pretty good about it. And, we had 3 guys in the back and I was running the call, but it's like, you guys know how it is. It's like all team stuff. It's like, hey, I'm going to jump on this. I'm going to jump on this. Mm-hmm. And we had one guy working on, airway, making sure his airway was good and basically bagging for this kid because his breathing rate was super random and weird. And we're like, oh my God, this kid is about to code on us. And in the back of the medic. And, what can we do? We're like, well, do we want to try and RSI him like right now? Or do we just try to do we prep him for RSI? And we're like, well, we got a short transport to the hospital. We're like 7 minutes away. Let's just prep him for RSI. So we gave him initial induction dose of ketamine, 150, because he was out and then he would do these, he would decerebrate posture and then try to lift his body off of the backboard, and we're like, oh my God, stay down, but he doesn't, there's no way we're going to reason with this, this patient or anything. So it's we got to give him something so he doesn't cause further injury to himself. And, we gave that 150 milligram induction dose on this kid and, just boosted him with as much oxygen to pre-oxygenate him for RSI and let the hospital know and kind of packaged them ready for the trauma doc that was there. And yeah, it worked great. It was one of those, it was wow, we just talked about this. And this is one of those cases where I think everything went really well with it, but it's also at the same time, I don't know the long-term effects. Obviously the long-term for this kid the outlook isn't great.
Sure.
But he's still alive as far as I know. So it's it's one of those things where, man, it seems like a really great drug that we can give and use. Just a tool. It's just another tool, but it's a really great tool that I've been having positive experiences with it at least.
Sure.
I haven't been oh man, I wish we wouldn't have given that one.
Yeah.
I don't think I've ever said that after giving it. So,
well, hey, we've got to wrap up our time. But Isaiah, I wanted to say thank you so much for joining us, and really appreciate your input. Super stoked that you're doing so well over there in Central Oregon, and really happy to have you on today, man. Thanks so much.
Yeah, absolutely. It's a fun topic, and I think just the more people talk about it, and the more comfortable people get with it too. I think it's the uses for it. That's the cool thing is I think there's going to be a lot more uses that come out in the future for it that we don't even realize they're there yet. Mm-hmm. That's why it's exciting. I think it's exciting for me. But
and
good
Steve,
to talk to some great minds.
Oh, well, thank
Nice.
you. I appreciate that.
He obviously doesn't know us very well.
I'm not 5-star, but thank you. And Isaiah, thank you so much for your service.
Yes,
100%.
thank you.
Yes, we sat over here and did nothing.
Oh, yeah, for sure. For sure.
Next time, it's going to be really good because I know I'm horrible at understanding the pharmacology behind a lot of the drugs we give, and it makes a big difference. And Dr. Selbach is going to be here. We'll go over the pharmacology. We'll go over the ketamine brain continuum, which is amazing.
Yeah, really good topic.
It is super amazing. And we'll get some. I'd like to start out with a case. Start with a case, end with a case.
Let's do it.
Sounds
All
good.
right.
Can't
All
wait.
right. All right,
That'll be next
Isaiah.
time.
We'll see you next time, buddy.
All right. You guys have a good one.
All right,
You too,
buddy.
man. See ya.
Bye.